the learning about communication and its importance has been a journey, and I'm still learning, and hope to be until the very end. I'm very much always open to new ideas and thinking about how things need to apply in different settings, in different environments. But going back to the early days, when I was a medical student and I was doing my pediatrics outpatient rotation, great to know that McGovern and I have a connection in the sense that I went to Baylor College of Medicine. So there's that connection. Very nice to know. But I was in my PD outpatient rotation, and I was with my chief resident, my senior resident, with him. And of course, I'm just a medical student, so this is where you move from didactics into the clinical arena, right? And it was an ambulatory setting. Mom came in. She was a new mother. She had limited English proficiency, and she came in and she had her baby. And he was, fussy and crying, tugging at his ear. So you probably know where I'm going with this. The child had an inner ear infection, otitis media. And so, he showed me, and of course we took the scope and took a look at the ear and all that. So I'm learning this, right? I'm putting to practice what I had been reading about in class. So I'm really excited. And of course, the prescription is antibiotic. It's amoxicillin because this is a bacterial infection. And he also spoke to the mom in Spanish. And one of the things he told her was, esta medicina es por el oído. So that sounds pretty straightforward. Translation, this medication is for the ear. However, the word por, P-O-R, can be translated as for, or it could also be interpreted by the recipient that's hearing this to pour. Por, you can also, for into the ear. And unfortunately, that's what she took away. And so it's a 10-day course of medication. She comes back at the end of those 10 days and she is distraught. You could tell she hasn't been sleeping. Her poor baby is just suffering terribly. And it became quite obvious to me at that point in time. And of course, being a Hispanic and Latino and also understanding Spanish myself, I thought to myself, I didn't catch that either. And hence the importance to learn, even when there's cultural concordance, you still have to be very cognizant of how do you communicate to ensure that what the patient or the consumer is hearing from you. And so it should have been para el oído. This is, para definitely is very clear. This is for the ear. And the other thing that I thought about when I thought about that case after the fact is that we didn't ask her to repeat back to us how to apply the medication. It's a very interesting, very good technique that we have learned that we can do. And it's not just a cultural thing, though it's important, but it's really good to have all consumers and all patients repeat back to us as providers. What is your understanding of now this intervention or this medication that I have explained to you? Because if they don't tell us what we thought we said, it's an excellent opportunity to ensure that we're all on the same page, that we're being clear with our communication to have the right outcome. Because we felt so bad, and I know my resident did too, about that poor child suffering for a 10-day course. And it also, and one last thing I'll mention, Mike, because it's so current and it deals with the task force, is currently the challenge of really distinguishing and ensuring that our communities, our providers, our stakeholders are understanding the difference between equality and equity. So that's a current challenge that we're seeing now and had some in-depth discussions, very robust discussions at the task force level.
That story about the medicine in the ear, I think, is one of the most iconic things I think about in clear health communication, health literacy work. And it's also, it makes sense. Like if I have a rash, I'm going to put medicine where the rash is. So it's a, like you totally get how someone gets there. And so that importance of communication, distinguishing, well, in this case, it's oral medication for your ear, not a thing to put in your ear. Like it's really easy to understand how someone hears what you said and does what they did. And it's not because like they're making a bad decision, like they're following instructions that make sense to them. And so,
Indeed,
in working with you over the years, and it's something I know we learned working with the Hogg Foundation, I think that you probably wrestle with it a lot more internally than we even might realize, is that there's a pretty big gap between the way people within an organization or within a project might think about the way we talk about a health issue internally. And people within your team might talk about mental health and the way to communicate about differently. We did a mental health symposium that I think the people from Hog were there. And we had this talk at the beginning to say, some people say mental health, some say mental health issue, some say mental illness. Some people all disagree about all those things. We're all on the same team. And so I'm curious how you think about navigating that as a leader when people within your organization might have different views of the right way to talk about a health issue, and then how you make that transition to the way people outside the organization are going to hear you, and how you have to go from the way we talk internally to the way our audience is actually going to hear what we're talking about to make the change we want to make in the world. I don't know. What do you think about that?
Well, I think you're landing on a really important issue. It's a challenge for organizations, and especially those that are maybe seen as leaders in, there's an extra, I think, maybe self-imposed, importance in wanting to make sure that we get it right, because so many people look to Hog, and we appreciate that, and that's a position we do want to be in. But we also realize that often it's really challenging and hard to ensure that hopefully we're doing the right thing. But I think getting to your point though about internally, as a leader in a position of authority, to ensure that we're moving in that direction and hopefully even actually achieving that, is to me that you have to start to think about your organization as a learning organization. If you initially think you're the one with the answers, you know what you're doing, what you put forth is it, you're going to find yourself making some missteps, and you're going to be criticized. And now this could happen anyway, right? But you're definitely, to me, ensuring that that's going to happen, because you're being way too self-centered and egotistical, in my opinion. But you must be intentional about actually creating what I think is important, which is a respectful, inclusive environment within your organization to be able to allow the discussion and the dialogue to happen with your team. And part of that also is the importance of having trust among your staff members to be able to feel comfortable, willing to share, willing to challenge each other, and to express, well, this is why I think it should be mental health, versus someone saying, no, I think it needs to be mental illness. Let's have a discussion and determine if that's the case, but you've got to have that space to share those differences of opinion. And that, to me, is on the leadership, especially the executive director, in our case at the Hog Foundation, to ensure we are creating that kind of a space. And that takes work. And it doesn't just happen overnight. This is a transitional sort of ongoing focus that you have to be thinking about the environment of your organization. And also externally, you need to know who is it your audience is. So say internally, you've landed on a certain term or an approach you're going to take to be inclusive. It doesn't always just translate easily then when you're dealing with the external audiences that you're going to want to deal with. For instance, using certain terms with our Texas legislature is going to shut the door in front of you if you're not cognizant of there are other terms we can use. But you need to have those discussions internally so that your team understands why these terms are not being used externally, and realizing that it's a strategic approach, because I always feel the outcome is one thing we really want to stay focused on, and of course our vision and our mission. And so it really gets to the point of what is this purpose of this communication effort, and what it is you're trying to achieve. And within that context, though, it starts, to your point, internally, and being able to have that environment that can sustain really, creativity, but also really getting back to the strategic learning organization, actual learning. One of the ones I've struggled with, Mike, and it's because language is so important. When we were kids, they used to say, sticks and stones will hurt my bones, but words will never hurt me. Well, we've all found out, and especially as a psychiatrist, well, that ain't right. And that is totally wrong. I've heard from so many patients over the years where, doc, I'd rather have a broken arm than to be dealing with the stigma of mental illness, because I can heal my broken arm. But that stigma, it follows you, it impacts you, it wears on you, and it takes its toll over and over and on and on. And so we need to be very, I think, cognizant and respectful of that to be able to deal with that. And so where I was going with that is, like when I was starting out in the field of medicine, and I used it over, quite liberally myself, was the word minority. But now it doesn't feel to be the right term. And the thing is, we're limited by the knowledge and the extent of our language sometimes. And I'm not sure where I've landed. I'm trying to use BIPOC, Black, Indigenous, people of color. And that one's is getting a lot of attention, but also is getting a lot of controversy as well. So to your point, and as we all know, and those that are listening, I know you know that language is a living thing. We're in the midst of this transition and the changes that are happening around us socially. And I think if we're open and respectful and willing to listen to each other, hopefully we can continue to navigate and move forward.
Yeah, and I see many smiling nods in the Zoom here of people kind of who are wrestling with this in their own work. I know we've had projects that started with like, well, we're all going to assume good intentions and try not to be too annoyed with each other when the language isn't quite perfect, especially doing it, live in a meeting or something when you don't have time to write it perfectly or think about it perfectly. A little while ago, you were talking about the difference between trying to understand and talk about the difference between equality and equity. And so I was wondering, because you have this role on the Biden-Harris Task Force for COVID Equity, can you maybe share a little bit more about what that work is in general? Most of us in this Zoom probably have never been on a White House task force, so that's pretty exciting. But then also, how do you think communication plays a role in promoting equity? Because I think that's something our center team's been thinking about a lot. People get into health comm because they want to use their communication skills and interests to promote equity. But just because people have good intentions doesn't mean we're putting the right systems in place to do it, or that we're doing it as well as we can if we put it kind of consciously in the middle of what we're doing. So I'd love to hear about that work broadly, but then also how you think communication plays a role in promoting equity in particular.
Absolutely. Well, one, it's a huge honor to be considered by the president for any task, let alone actually getting selected. So I was one of 12 non-federal members across the nation that was asked to join the task force. Of course, I said yes. It's kind of hard to tell the president, no, I think I'll pass on that. Because, it's such an important task that the president has identified. And of course, it speaks to me personally, not only in personal, but then it's the function we've been doing at the Hogg Foundation. I think it's the work of the Hogg Foundation and my amazing team that caught the attention of the White House and asked us to be there. And of course, the challenge is great because I'm the only Texan on it, and I'm only a psychiatrist. So it's like, oh boy, I'm representing practically 30 million people, not to mention the whole field of psychiatry. Oh my goodness. But I take it with great relish because I can reach out to my networks, the folks I know, to be able to ensure I'm representing. Hopefully, I will do more than my best to represent us all well. But the mission of the task force, it came from an executive order from President Biden. He asked that he wants recommendations that will mitigate the inequities that we have seen with COVID-19. And also, though, it's not just ends there. It's also for preventing inequities into the future. So that's a big charge that's been given to the task force. And we were all taking it quite seriously. And the four main focus areas were created with respective subcommittees, Mike. And can't be on all of them, but I'm on 2 of the subcommittees. However, as task force members, we also then weigh in and interact, obviously, with our other subcommittees. And so we all get to weigh in on everything that's being developed. But we have groups of the task force members that are dedicated to one subcommittee or another. The 4 sub-main committees are the data, analytics, and research is one subcommittee, and that's the one we actually started work on initially, followed by health access and quality of care. The third one is structural drivers, also known as maybe the social determinants for some folks, and xenophobia. And the fourth one, communications and collaboration. It was recognized initially how important communications really is when it comes to the delivery of care, the implementation of care, but also ensuring that we're actually receiving and acquiring the right data to be able to make evidence-based decisions that truly are respectful. And getting to your point, it's good to have good intent, but the rub is, are you having the right outcome? And so you've got to look at both the intent and what is the outcome from that intent. And so within that construct, I think it's so important what the Health Task Force is doing. One of the first things we had to tackle and recognize and own is the fact this is a new administration, obviously a new charge from President Biden and Vice President Harris, and recognizing due to difference of opinions and approaches, there was some damage control that we need to do out the gate because of disparaging language that had been used by our leaders at multiple levels, not only at the federal, but even all the way down to the local level, by individuals with authority. And it has had an impact, and we're still sort of dealing with that kind of approach that was taken. Recognizing, getting to your point about communications, our discussions centered on the federal government needs to be communicating clearly, concisely, and a person-centered approach to the communications, because it's about the science, but it's also about the risks and the benefits. We need to be able to address all of those so that each individual in the United States can make an informed decision on their own behalf, as well as our stakeholders, our policymakers, and our leaders of authority are doing the same thing. And also recognizing mass communication versus, say, targeted communication for our communities. And it seemed like it was one or the other, and we argued and landed on and understood these must be aligned. And in fact, they're not mutually exclusive. You can have mass communication, which does need to be done at some level, but at the same time, there's no reason we can't really be reaching down to the community level, really partnering with community-based organizations to ensure that certain communities which have been marginalized or historically excluded are also being addressed in real time, and not like, oh, we'll get to you after the fact, which unfortunately has been a part of the issue, because even if it wasn't intended to be, it kind of came out that way and people perceived it as such. And if it's perception, it becomes reality. That's another thing to really understand. And also getting back to what I had talked about earlier with my story, is then we need to understand all the different audiences that are out there and partner with the trusted voices. And a trusted voice in one setting may be different from a trusted voice in a different setting. And then in my opinion, within that context, if we're really going to achieve health equity, it means we're really respecting all our community members. So it's front and center, Mike.
No, that's awesome. I mean, the number one thing, I mean, I've heard Jay say this, we say this in all our work all the time, like there is no such thing as the general public. There's 320 however many million Americans, and that's 320 million individuals, and they're not the same, and no mess is going to work on everyone. And so it's exciting to hear the way you thought about that. So to pivot back to mental health a little bit, one of the pre-submitted questions we got was about health journalism. And so the question was, if you could change one thing, or maybe two things about the way journalists write and report on mental health, how would you change how journalists report on mental health issues?
That's a really good one, and I really like that one. And I'll tell you why, Mike. Once I'm going to go a little bit to a story of the Hog Foundation, because I recognize, and made communications its own unit at the Hog. One of the things that I discussed with my director of communications at the time was, what could we start doing? Like we partner with you. Of course, this was like a decade later. Wish you had been there at the beginning. Things may have been a little bit different, Mike. But we reached out and we're looking for how can we help educate journalists? How can we ensure that health communications is being holistic and inclusive, and understand there's no health without mental health? And our initial forays into it didn't pan out, and it really, I really felt. I'll give an example of one of the. There was up in Massachusetts, I think it was Boston University, if I'm not mistaken, who had a program where they would bring in a journalist who was interested in mental health. They go through a week of training, and then they would have the skill sets, right, to be able to do mental health reporting. And we chose a reporter in Texas that responded to a request for proposal. We did an RFP. He was out of the Dallas area. We paid for this. We sent him up there. We paid for everything, and it was a pretty penny. And when he came back, he decided he wanted to be reporting in mental health, and we're like, but we just invested all this money, and so that didn't come out too well. My first foray out the gate. This was back, I think, in 2009, 2010, sometime in that time frame, Mike. And so, but that's on us. I think that doesn't mean you don't stop and keep trying. It's just lessons learned of what may be the best way to go. But getting to the heart of that question, I would say that, boy, if I could ask you to do one thing, guys, is don't perpetuate the stigma of mental illness, substance use, or IDD that currently we are still having to battle. The stigma with, say, post-traumatic stress disorder is definitely different from what it was in the 1970s, when our guys and gals were coming back from Vietnam and what they endured, versus the PTSD is much more acceptable in this day and time. Same can also be said. I think we're making progress in anxiety and depression. Schizophrenia still, and the psychotic disorders, that's a tougher one. We have a long way to go. But don't contribute. Thinking about, use a health equity lens as you're writing your story, as you're interviewing and thinking about the questions and the data and the research and writing the story, that it's not perpetuating that stigma. If you could do that, I think that would be so helpful, because thinking about all the different ways that now that media, the different types of media resources that exist out there. It's not just the written word on a newspaper anymore, or the radio, or even the television. Now with social media and other ways that keep popping up, and these apps and everything, there's just wonderful opportunity to help really tackle stigma and to eliminate it, hopefully at some point, because no one should be defined by their illness. We shouldn't be using the term like, oh, the schizophrenic said this, or he referred to him as a schizophrenic. No, you're taking a person's entire life and saying all that matters is that he has schizophrenia. And to me, that is just it's not right. In my opinion, it almost borders on being unethical, especially for a physician or a provider, even worse, because our code of ethics is primum non nocere. First, do no harm. You're calling someone a schizophrenic or a diabetic, or using any kind of illness to identify an individual, you are doing harm. And we know that is the case, because language is so important. So, person-centered language needs to be become the norm instead of what has been done historically, because it really puts the individual first, right? Because like I said, people are so much more than their disorder or their mental illness or their disability. And using person-centered language respects, it brings dignity, worth, identifying the unique qualities. That's okay. That's what makes us who we are. None of us are cookie cutter. Getting to your point, Mike, about a general audience. No, there's about 300 million of us. And so being more of a strength-based approach, I would say, for every individual.
That's great. Thinking about the way we train future communication professionals in our college, with, our School of Journalism and students getting, degrees in advertising and public relations and communication studies. These are the kind of skills, like it feels really important to kind of help chart the way future journalists are doing this work. And I think there's the way that this can be built into training is so essential. Thinking about our campus, another one of our pre-submitted questions is about like UT itself. And so do you have any thoughts on how people at UT, whether they be faculty, staff, or students, can think about sort of helping to dismantle inequities on our own campus? Because, it's the whole what starts here changes the world thing. And so if we can't think about how to make UT a more equitable place, it's hard to start then thinking about how we can do it beyond UT. So do you have any thoughts on how we can kind of improve equity on campus?
Boy, I mean, that's a really good one too. Boy, you guys came up with some really good questions. That's a huge and challenging one, right? I mean, as we all know, we're in the midst of the Eyes of Texas, and there've been other issues before that, like with the statues, but these are issues and concerns that we do need to be addressing. And at the University of I'm a University of Texas alumnus. Got a bachelor's degree here and a master's in business administration. And of course, now I work for UT. I've been a health science center professor in San Antonio for UT Health Science Center. So, pretty close to pretty having orange blood, really. So I care which means I do care a great deal about UT Austin, and are we doing the right thing and moving in the right direction, to your point, Mike. And one of the things that comes to mind that I would put out there, that it needs to be done at the leadership level, but I think there are things that we can all do to be able to ensure that we're dealing with inequities that already exist and continue to maintain equity. Because here's the thing, it's not a one-off. working with against disparities and equities. This is for the rest of our lives and generations to come. Because even if we do achieve it, then we're going to have to maintain it. Because knowing human behavior and knowing about entropy, you got to, things have a way to start to unravel if we're not being don't have intent and thinking about what's happening around us. But it makes me think about one thing that's really that we work with at the Hog and care a great deal about, which is being trauma informed. I think recognizing all the different individuals that come to the University of Texas, not only our students, but even faculty, staff, visitors, and we all have a history. And we all, unfortunately, because I know the statistics, have in one way or another, a great deal of us have dealt with some kind of trauma. So I think understanding and helping for us at the university, who are the administrators and the teachers and the staff, to understand the impact of trauma that it has on an individual. And therefore moving us, if we have that understanding, I think it then sets the stage of how we actually truly make this campus a safe environment. And not just from a physical standpoint, but also from an emotional standpoint. If we can do that, we will make great strides. And that includes the hard questions and the hard issues, which means we can't ignore and we shouldn't avoid discussing racism. Our history of it, its current structural racism implications, and how do we avoid it in the future of making unintended consequences. We've got to be critical thinkers. I think also part of that, especially in the here and now, is understanding and learning about and even acknowledging microaggressions. They're happening all the time. And if you're not feeling them, then it might be because you're actually delivering them and not even know it. And so getting back to intent versus impact, my intent wasn't to have a microaggression. I mean, I've had this happen to me, but I've seen it happen to others much more. Like, oh, you're so well spoken. That's a microaggression when you say that to a person of color. Oh, you're smarter than you look. Gee, thanks for that. I mean, it's these sort of veiled compliments, but they're seen as microaggressions. And at first blush, you may think, well, I didn't mean anything by that. I was being complimentary. Understood, but when you put yourself in the other person's shoes, and this is the first microaggression that they've encountered, and it's been happening since the day they were born. Guys, we now know, getting back to language and the impact on a biological level, what is the wear and tear that it's happening on our individuals, and it's mostly our populations of color, but not only. This also happens to our folks that are dealing with any kind of a mental or physical disability. I mean, there are definitely, we need to be thinking, inclusively there. I would also really want us to look at the way we educate and our educational activities in the sense of, it would be really important for us to start moving and thinking about all these activities we do through a health equity lens. Or just an equity lens, because that would really start to help and understand as you're thinking about, well, I teach architecture. What does that have to do with equity? Well, truth is, there's a lot that it has to do with equity, the built environment, my goodness. But how are you teaching it? Are you teaching it where it's inclusive? Are you pulling in, diverse students into the discipline, the profession, into your class? Are you being thoughtful about that? And that's what I mean by having an equity lens. And also tied to that, which I think it's more on the administration, is thinking about how do we help our professors and our teachers and our lecturers to do that. Well, one thing in my opinion is we need to be evaluating it. If we evaluate it, it becomes part of how we see your acuity and your skill set. It means it's important. And people respond to what's important. And it would really help to determine also identifying, though I don't want to be draconian about it, but what data analytic metrics should we be developing to be able to provide that kind of feedback to our professors, to our lecturers, and those that interact with students. And then, of course, I think one of the ones that we've been struggling with a great deal, but we doesn't mean we should let up on it, is we've got to ensure that the UT is as diverse as the population is. And so we still need to recruit, we need to admit, we need to hire, we need to promote more faculty, students, and staff of color. And I'll end on this because it isn't just about the diversity itself, because the non-white colleagues of ours, be they students or professors or whatever, the role that they can play is allyship. So, what's an ally, right? So an allyship. So it's being actually active and consistent, and it's an arduous process of unlearning as well as evaluating that you're a person of privilege. And I know that that can be very difficult for some, and it is, because if it wasn't, then we would have done it. But we don't, and that's because that's how tough it is. And also being able to self-reflect and identify, gee, that is happening. And so when you operate then in solidarity with others, then actually we can all be making progress together, because it's going to take the whole village. It can't just be on the non-Hispanic white colleagues, and it can't just be on the people of color colleagues to do this. It really has to be a synergistic, unified approach to be able to make the University of Texas, in my opinion, a place of equity, and one where we're diminishing, if not eliminating, the inequities that currently do exist.
An exciting vision. I don't technically have burnt orange blood yet, but after this many years here, I feel like it's slowly shifting in that direction. I want to go to the chat window. We had a question from Carolina here. I want to say thanks for submitting this in the chat window. Her question is, how do you best communicate about mental health and reach communities where mental health might be stigmatized? And cites as examples Latinx or other immigrant communities. So any lessons learned from the Hogg Foundation as you think about doing outreach specifically to communities where mental health stigma might be a little bit more common?
No, that's a really good question. And what I love about that question is it's real. It's what we're dealing with front and center now. So this is the approach we're taking at the Hogg Foundation. Number one is understanding the approach and the philosophy of true community engagement, and going in respectfully that the community has the answers. Often what community needs is a partner, maybe some resources. It's not always about money sometimes, guys. Sometimes it's really just about elbow grease, or being able to have a dialogue or a perspective, an approach to do that things. But for the Hogg, it's about that community engagement. And the other thing I will say, Mike, is that too often we don't give enough ourselves of this. So important to achieve what that question is, to me, is getting to the heart of, that we don't spend enough time developing the relationship that is needed to then have a truly in-depth discussion on a very intense and difficult issue. We want to jump in and do. I'm a doer. I want to do it too. But sometimes you got to put the brakes on and realize, no. I'll give an example. We've had some great learning happening in one of our initiatives called Wellness in Rural Communities. And so we have identified and are working and partnering with 5 rural communities in the state of Texas, 5 rural counties, to create a collaborative, and working with them and watching them. How do they actually get to addressing, say, the issue of stigma with mental illness? What it takes is of identifying who are considered the leaders in a community. And then it doesn't end there, because those that have been identified are the usual, what are called suspects. And then it's working with them and starting to really open up, and which was our charge. How are you including your marginalized or historically excluded members of your community, of your neighborhood, of your county? And you start to challenge, and they have to start working through that. And then they need to bring those folks on board. And that's when you start to build real relationship. You start to work on and create trust among the members to then be able to get to that very question, which is, now what do we do? And we understand the stigma that does exist. So with Latinx community, with Latinos and Hispanic populations, you have to go through that same process, and you have to be respectful. And it does take time to identify who it is you need to partner with, because you pick the wrong partner, guess what? You're not going to get too far. And here's the other thing: you do have to give yourself grace that you're going to make that mistake, because it does happen. And then realizing, okay, it doesn't end there. Let's use this as a learning opportunity, and let's go back and let's continue. Because the other thing that communities of color and Hispanic Latino communities, especially here in Texas, you've got to show that you're going to stick around. We're pretty used to the professors and the foundations coming in, doing their thing, and boom, they're gone. They publish and whatever, and you left us with what? Where's the sustainability? What kind of capacity building did you do with us? Did you really partner with us, or did you just use us? That you have to work through, because many community members are bringing that to the table because of, unfortunately, previous historical interactions that have happened. And getting back to my point, you've got to give yourself the time and go, if you're really going to do this, you're going to do it right, or well, I should say not right, but well, you're going to have to commit yourself to really going down that path and journey. But we're 3 years into our 5 collaboratives in the 5 counties that are part of our Wellness and Rural Communities Initiative. And what we're starting to see now is just truly amazing. And it's heartwarming, and you realize that investment in that time, my golly, it was well worth it. And we've learned so much from those communities, because it's a two-way process. It's not so much what we brought as much as what we're sort of also bringing, and they're bringing to the table themselves. So it's a wonderful question, but that one is one that I'll start with, take the time, because if you do that and you do it respect, it's also being about respect, and it's about listening. When we go to the community, we're not the ones talking. I know I'm doing a lot of talking here with Mike, but when you're going to community, you want to make sure they're talking more than you are, because if you're talking more than they are, it's a red flag.
You're here to share today. We're here to listen to you. So we appreciate you sharing all this. We're starting to run a little low on time, but I want to sneak in 1 or 2 more questions here. And so I saw a question just come in from Sean. And so we have a question here that says, what are ways healthcare providers can effectively identify stereotype threat in sort of thinking about and caring for diverse communities in Texas?
Mike, could you repeat the question again?
Sure. Yeah. It's what are ways healthcare providers can effectively identify stereotype threat in caring for diverse communities across Texas?
Oh, yeah, the stereotype threat. I think that's a tough one. And to be able to identify the stereotype threat, it really has to start internally with the individual, the provider themselves, because we're the ones that are contributing to that stereotype threat. And I'm a physician, and I just have to say, my colleagues and myself, we still have so much to really learn, to practice, and to have supported when we are trying to do the right thing. I know this might be a little bit more upstream than what the question would like me to direct, but I really feel that we're part of where we can get to this answer and make the change is we really have to concentrate on instilling and developing the right skill sets when we're in training. And we are still not doing that in general. I was on the National Academies of Sciences, Engineering, and Medicine's, committee where we evaluated GME and graduate medical education, and the inconsistencies, the lack of accountability, the lack of oversight. This is inside baseball stuff. I hate to share it with you guys because it makes us, and I'm only talking about physicians here. I'm not talking about our nursing colleagues, our social workers, our psychologists, and the list goes on and on. I'll just talk about our medical training. It's falling way short than where it should be. We know what we need to be doing, but we're not doing that. Too many of us are steeped in the status quo. And here's a truism that I've discovered over the decades, which really sometimes I try to figure out, okay, how am I going to change this? and I can't do it myself, but people ask for change until you start changing things. And all of a sudden they'll go, well, hold on now, that's too fast. They start putting on the brakes. And yet that's what we need. That's what we need to happen. We need to have the skill sets that we're being taught need to be ingrained in doing the right thing. What we have done and continue to do is, if we teach the stereotypes, which we do, then are we surprised then by the outcome and the manifestation of them happening? And hence the way we are treating communities monolithically, and we're using the stereotype to then actually not only we use it against them by the fact that we'll identify and pull out, well, this is why we don't need to do this, or this is why they have that kind of an outcome. And because the corollary to that, if we are being taught the right skill sets, is identifying truly the structural or political determinants of what is really influencing me to treat you as a stereotype.
It's so interesting. I'll bring it back on my faculty, because I'm not a physician, I'm not a nurse, I'm not anything. But throwing on me and my faculty friends, we talk to people all day long, and I think there is this tendency to imagine just because you communicate all day long that you're automatically awesome at communicating. And our colleague David Ring talks about, how can you make people consciously incompetent? Like, how can you help make them aware of where they have room to grow and how they can get better? And so I've always particularly loved that kind of framing of kind of coaching people on getting better at communicating. It really speaks to, I think, the idea of skills building, whether it be as nursing students, medical students, all the way along the line, and then continuing education as actual professionals, I think is really crucial. We're running very short on time. And so I want to both, one, say that one of the giant upsides of a virtual McGovern Lecture in health communication, as much as I would love to be together in person, is we would not have attendees from, I think, at least Minnesota and Nigeria in our window right now. That's not possible in the before times. And so, part of it is saying thank you to everyone who attended, however you found us. Like, the big, broad audience that's bigger than we could ever put in a room at UT makes this really exciting. And I also, before we wrap up, I just want to say, Dr. Martinez, one is thank you so much for being willing to kind of give this talk today. We're so proud and excited that you're our 2021 McGovern kind of award recipient. But do you have any parting thoughts and things that you hope people take back to the rest of their afternoon, their work in the coming weeks, as it relates to communication and its role in promoting, mental health and health equity?
You know what? Thank you, Mike. What I would say to folks, and this goes for me as well, because you've asked, you and the audience have asked some just really great questions, and I want to take some time, and I think we all should take a little bit of time to sort of reflect on, what you've heard and during this discussion, and identify where is your role personally. Because getting to your point, Mike, about how we are able to really move forward, we really have to start with ourselves. And this is my psychiatry coming out, but the truth is, it really is. When I think about my, colleagues that are providers, for us to not stereotype folks, for us to truly be treating individuals as individuals and being person-centric and family-centric and community-centric, you've truly got to start with yourself and be honest with yourself. As Shakespeare said, to thine own self be true. You've got to identify, what are my biases? What are the things that rub me the wrong way when it comes to other fellow human beings? What is it I like and don't like? How do I respond when I see someone that is different than me? Why, when I was walking down that sidewalk, and it was, 4 young black guys with baggy pants, did I decide I wanted to cross the street? Initially we'll go, oh, safety, but you need to get beyond that. You need to really start digging and going, why do I do what I do? What impacts my human behavior and my personal emotions? Because if we can start there, all of us, including myself, then we can really start to recognize not only our humanity, but also because we have something called, an executive functioning of our brain, which is so important right here in this part of our calivarium, that can allow us to overcome knowing the evidence and the research showing of what really should be, how we should be responding in certain situations, like in a clinical situation, or when we're responding to a community, and why sometimes we're defensive, and why it's so hard for us to accept that we're part of the problem at times. And I could go on, but that would be the one thing I would leave with folks is if you can start with yourself, I think you can really start to unravel the mystery and really the amazing humanity of yourself, and then how that actually plays and when we're interfacing with another human being.
Well, Octavio, on behalf of Dean J. Bernhardt, the Moody College of Communication, our whole Center for Health Communication team, I just want to say thanks. This was it was a well-spent hour, according to someone in the chat, and I couldn't agree more. This was really fun. I think everyone learned a lot. The idea of reflecting on ourselves this afternoon is probably not the worst call to action from today. And just really want to say again, congratulations and thank you so much for being part of the event today. This couldn't have been a more fun and rewarding hour. So thank you so much.
Well, you're welcome, Michael. Thank you so much. And also to Dean Bernhardt, thank you, sir. And everyone that was here, thank you so much for spending some time with us. So, it just means so much to me. Thank you.
All right. Thank you, everyone. We'll see you next year for the next McGovern Lecture. Octavio's left big shoes to fill for our next speaker. So thank you all very much. Have an excellent afternoon.